This is the presentation, first presentation in the chest, prepared by Prof. Sharaf and revised by Professor Sabri. We will deal with the radiological anatomy of the chest, some aspects. This one is the slide showing some differences between erect AP and BA standard films. What are the differences? You can see, and why they are, and all of course are due to magnification. The heart appears larger because it comes away from the cassette in the erect film AP. The mediastinum appears wider. The diaphragm appears higher due to magnification of the anterior subdiaphragmatic structures, thus apparently less inflated. Between expiration and inspiration, what are the difference? What is the cause? And why we use it? We use it in some cases of inhaled foreign bodies or to detect focal emphysema, as when the patient inspires, the healthy part will get inflated, while the obstructed part by the foreign body will becomes less, and the reverse. If expiration, the healthy part will be less aerated, the emphysematous part will still be emphysematous. The heart here in expiration appears larger because horizontal orientation. Expiration makes the diaphragm higher, and thus the heart acquires more horizontal orientation. And the basal opacities here are not due to disease. It is due to the basal opacities are due to deaeration. Difference between soft and hard. Normally we can see the spine as a column, dense column, but not to see the spaces. So the difference is on the left it can appear as a dense column. On the right, if it is hard film, you can see disc spaces. If you want to see an apical mass, it's better to do it posterior as standard and AP lordotic. But of course the AP lordotic is better. The differences, it is due to the position of the patient and the direction of the ray and the angulation upward. This makes the APCs more clear. The patient acquires a lordotic position with upward direction of the ray, and thus the upper lobes, supraclavicular regions becomes more clear away from the clavicles. This is what we call it lateral decubitus. If there is fluid and air, it becomes evident that fluid can seep up, or air fluid level can be seen. Thus lateral decubitus is sometimes beneficial in cases if there is collection behind or below the diaphragm. We call it below the lung, and this is called the subpulmonic effusion. Subpulmonic effusion. How to read chest X-ray? Consider the image as a patient facing you and check the marker, because this is essential. You find right and left. Patient facing you, that means his right is opposite to your left side. You are a clinical radiologist and not just a reporter. Be sure that the position and the data and the factors all are good. all chest limits should be included. All the costal cartilages should be included. The diaphragm should be included. Costophrenic angles, APCs, and the trachea should be centralized. Clinical examination should include inspection, as if you are inspecting the surface of a body. So we are inspecting the soft tissues to exclude mastectomy, for example, and then we palpation, as if we are palpating bones or bony cage, and this we search for congenital lesions or fractures along the ribs, sternum, spine, related parts of the shoulders. Chest wall anatomy include, of course, the breasts, the ribs, the soft tissues, and the sternum. These constitute the chest wall anatomy. What is this? If you look carefully, you will find some round opacity is seen at the left base, but if you look on the other side, you can identify such a similar opacity superimposed on the lower anterior part of the 6th rib on the right. These are the nipple shadows. These are the nipple shadows. This is an example of a 3D reconstruction, 3D CT reconstruction. You should be careful whether you are looking for anterior projection or posterior projection. This is, of course, posterior projection. Ribs are slanting anteriorly, reaching to the midline, but they are not reaching to each other anteriorly, while posteriorly there is definitely costovertebral junctions. What continues with the ribs anteriorly is the cartilage, and this cartilage calcifies with age. Posterior ribs reach the spine and are upward slanting from lateral to medial and are more to be transverse sometimes if you go up. Volume rendered CT for the ribs. The left image is for sternum and the right is for the spine, posterior part. Anterior ribs, posterior ribs, anterior ribs to the left and posterior ribs to the right. What are the intercostal grooves? What is running? Or what are these fine dense structures running in these intercostal grooves? Of course, these on the inferior inner surface of costal of any rib, on the inferior inner surface, there is a costal groove in which an intercostal artery, vein, and nerve run. So be careful while doing any intervention, because you might injure the lower margin of the you might injure an artery along the lower margin of a rib. Volume rendered CT of the sternum. The forms are best seen, of course, in the sagittal view. So mention two deformities of the sternum. We can, all of us know that there is what is called as the pectus excavatum, and that means there is a depression. This is the most common deformity, and it is previously related to those workers in shoemakers. The second is the pectus herniatum or the pericardial bulge, which represents an abnormal protrusion of the sternum as in congenital heart disease. Alongside and parallel to the sternum are the two internal mammary arteries from inside, and these are seen here as two linear shadows, internal mammary arteries. But again, the arteries are accompanied with veins, and so we have internal mammary arteries and internal mammary veins, and all are parallel to the sternum, running inward. The first costochondral junction is cartilaginous, of course, partly cartilaginous and peripherally bony, is particularly bulky and can mimic an underlying pulmonary nodules, particularly if they are asymmetric and if they are calcific more than the other side. So it can mimic a nodule. What are the important anatomical landmarks in counting ribs on axial CT? And what is the angle of loss? Counting the ribs on axial CT can be done using three anterior anatomical landmarks. Rib 1 is posterior to the clavicular head. Rib 2 is at the sternal, is opposite the sternal, at the level of the sternal angle, or what we call angle of loss, which is opposite T4 vertebral body level. And rib 7 is opposite the xiphoid process, which is at T9 vertebral body level. So what are the three important anatomical landmarks in counting ribs? It is posterior to the head of the clavicles is rib 1, opposite to at the level of the sternal angle or T4 is rib 2, and opposite to the xiphoid process is rib 7 or T9 level. The cephalad border of the pericardium, the cephalad border of the pericardium is at the level of the sternal angle. The normal pericardium measures 1 to 2 millimeter in thickness on CT and MRI. Again, the cephalad border of the pericardium is at the level of the sternal angle. The normal pericardium measures 1 to 2 millimeter in thickness on CT and MRI. The 12th thoracic vertebral body forms the normal kyphosis of the posterior chest wall. The normal kyphos along the dorsal spine is made by the 12th dorsal vertebrae. Its height is smaller anterior than posterior. If there is straight back, this will result in thoracic scoliosis, pectus excavatum, and is associated usually with mitral valve prolapse. So again, the 12th thoracic vertebral body is the responsible one for the normal dorsal kyphosis, and number 2 is the straight back syndrome may result in thoracic scoliosis, deformity of the sternum as pectus excavatum, and usually associated with mitral valve prolapse. What is this? Even in a chest x-ray, we should look for spondylosis. On the left side, ossophytes are smaller due to pulsations of the heart. On the right side, they are usually larger. Thank you.